Good evening, Dr. Els. Hi, Dr. Els. Can you hear me?
Hi, how are you?
All right, and yourself?
Good, thanks.
Do you want to try test your screen quickly?
Yeah.
Okay, I
Can you
can,
see it?
yeah, I can see it perfectly. Thank you.
Okay, cool.
Okay, so then Farana will be on in a few minutes just to introduce you, and then
Sure.
at 7 I will start admitting, but I'll stay on in the background if you need anything.
Okay, no problem.
Okay.
Thanks.
Evening.
Hello.
Are you Dr. Els?
Yes, I am.
Hi, nice to meet you. Good evening. Thank you so much for standing in today. I'm Farana.
Hi, Farana. No problem.
Yeah, one of the physiotherapists on the CPRG group.
Okay.
I hope Dr. Roo gets well soon. And sorry to
I
put you
said
under
to
the
her
pressure.
no, it's okay. I said to her last week she doesn't sound well, and then this morning when she phoned, I said, "Oh no." So
Oh,
yeah,
shame.
pleasures of working
Yeah.
with kids, no?
True, True. And I'm sorry that we can't, it's not, we wish we could cancel, but it's not that simple. But
No.
we
Sure.
really appreciate having you. And I see Tammy's online. Tammy, thank you so much for
Hi,
everything for today.
Farana. No problem.
Been a day, and a half. I've also just come out of literally 3 different workshops today. So I'm looking forward to just listening tonight. But I hope I do the CV proud. So thanks again, Dr. Els, and Tammy will just wait for the rest to join.
Sure, as soon as you're ready, Farana, just let me know and then I can start admitting.
Yeah, no, I think I'm ready. I've got um the CV on Word, yeah. So I'm just going to I'll put on my camera and just greet everybody, and then I will introduce Dr. Els and we can start.
Okay, perfect.
Okay. Shall we give them till 5 past 7? Give them till that time before I start, or what do you say?
It's fine with me. If it's fine with Dr. Els, then we can do it that way.
Okay, awesome. Thanks, Dr. Els. Tammy, I think there are a few people that are waiting in the admitting room based on my WhatsApps. I
Okay,
think
so can
it's
I start
Marley and
admitting? Can I
yeah,
start admitting? Okay.
yes, it's 7 o'clock. Thanks.
Okay.
Good evening, everybody. I'm Farana, Dr. Farana Karachi. I am just going to welcome you this evening. For now, I'm just going to give everybody a little bit of time to join on. And so if you have joined, we will give some of the participants another 3 minutes, and then I will do the necessary welcome and introduction. Thanks for being here. Okay, good evening, everybody. My name is Dr. Farana Karachi. We are 1 minute away from starting. I said I give 5 minutes for people to join, and I think we're about 16 participants at the moment. I would like to welcome everyone. It's 7, sorry. I'd like to welcome everyone to our two-part talk on asthma in little lungs. So welcome. I just want to say for this evening, I just firstly want to wish Dr. Adele Roux, who would have been our speaker for tonight. She is recovering from having flu, and so we wish her a speedy recovery. But in her place, we have Dr. Carla Els. Sorry, did I hear someone? Tammy, can I go ahead?
Yes, you can.
Okay, thank you. So yeah, I'd like to welcome Dr. Els, who's going to, I'm sure, going to do the talk justice this evening. And before we start with her talk, I think it's just appropriate to do a little bit of an introduction in terms of who Dr. Els is. So firstly, Dr. Els is born in Johannesburg and is living there currently, married to Francois, has a little boy, Zeke, and she matriculated in 1996. She has got an MBCHB. She got it in 2002, and she specialized in pediatrics since 2005 at the University of Pretoria. She has a diploma in child health and has successfully completed her MMed and FCP examinations during 2008. She also completed a fellowship in pulmonology in Louvain, Belgium, 2008 to 2009. She completed her certificate in pulmonology and a diploma in allergy in 2010 at the University of Pretoria, and she's been registered as a pediatric pulmonologist since 2011. She was a recipient of the Golden Key International Honor Society Award in recognition of her academic achievements in 2001. She has a special academic interest in asthma and allergy, cystic fibrosis, lysosomal storage diseases, and non-invasive ventilation. And her hobbies, her 2-year-old reading when she's not sleeping. That's very sweet. Dr. Els currently works in private practice at Netcare Linksfield Hospital. She is a member of the Scientific Committee for Cystic Fibrosis in South Africa since 2011 and the chair of MCAC. She'll tell us what that is in 2012 to 2015. She's a member of the Lysosomal Disease Advisory Panel since 2012. And she's a member of the Allergic Rhinitis Working Group since 2012. So she's a very busy doctor. She's traveled widely through the world to broaden her professional knowledge and to present her work at conferences using posters and other oral presentations. She has 10 scientific papers to her credit and had numerous amounts of formal presentations. And her presentation tonight is titled Preschool Wheeze, Asthma in Little Lungs. So Dr. Els, welcome and thank you so very much for doing this presentation tonight, and we look forward to hearing all the interesting information that I think will be useful to the community of practice here tonight. Thank you so very much.
Thank you, Verona. First of all, disclosure. I did not prepare this talk. I got a desperate call this morning from Dr. Roux to ask if I could stand in. But yeah, this is our bread and butter. This is what we do every day. So I hope I can enlighten you guys and maybe give you some small, a bit of help and little pointers that you can use when you see these little kiddies with their chest problems. Just regarding my child, I changed the age, but it seems like I sent you the old CV for Anna, so my apologies. He's actually now turning 9, but it's more like 9 going on 19. But anyhow.
Oh my!
So, but yeah, I said to him tonight, now I'm going to do a talk. You cannot interrupt mommy. No, okay, you won't. But I can not guarantee he might not barge in here. So my apologies in advance. But yeah, let's not waste any more time and let's go ahead. So yeah, Dr. Adele Roux is based in Pretoria, but we basically studied together and she was my junior and I was a senior. And when I was a consultant in pediatrics, she was specializing in pediatrics, and then I left to go and do pulmonology overseas, and she then furthered her studies as well. So we found each other quite often, and we quite closely discuss patients here and there where we do have issues. So yeah, preschool is it asthma in little lungs? And I think that's still a question I sometimes struggle with, so don't feel alone. So what is a wheeze? So the term wheeze is often misclassified, and audible wheeze is more often than not a late presentation in airway obstruction. And to be honest with you, it's actually not such a common presenting sign in pediatrics. There's also no data on the sensitivity or specificity of these terms, wheeze. And more often than not, I don't know if you guys realized, but if you ask a mother, so what sound does the child make? They more often describe something different to a wheeze. Might be a stridal, might not even be a wheeze, or might just what I call a percolator sound, where you hear mucus in the upper airways. A cough correlates with lung function and atopy in preschoolers, similar to and independent to a wheeze. So the question I usually ask them is, does the child have colds and flus that go to the chest and make them cough? So that is actually the most common symptom that we see in these little ones. So wheeze is a common symptom according to Hans Bisgaard. I cannot vouch for that in my practice. In the later ages, yes, not in the little ones, unless they have really viral components, but we'll chat about that later. And asthma is a common problem, and it should be controlled. I mean, we are one of the big countries in the world that has a very high incidence of asthma, and asthma still remains one of the top 5 killers amongst children. But not all wheezy children becomes asthmatic. So my first thing I tell all parents is, yeah, the 4-year-old comes into my office and they say, so doc, is this asthma? I said, well, honestly, I can't really say that it's asthma, but only 13% of these kids can become asthmatic. And you should take heart from that, because that is actually quite a low value and it's quite rare in that instance. So because we found that a lot of these wheezing preschoolers don't have asthma, there are different bodies of evidence that look at the wheeze and if it's asthma or not. So we'll discuss that in detail. So the first one is Martinez. So I did my training, and Martinez was the very first one that everybody was quoting. And it's also because it's one of the biggest ongoing birth cohorts, which was centered around asthma and chronic obstructive lung diseases in the world. So he had different phenotypes, and he said there was a transient early wheezer, persistent wheezer, and a late onset wheezer. And the patterns would differ for these patients. So the transient earlier wheezer, they wheeze before the age of 3, but it's better by the age of 6. So once again, that percentage of 13. Typical features, it's the smaller airways, it's usually viral, and they're usually not atopic. And they have a normal lung function later on in life. So lung functions, we can probably start doing from about 6. Today, I was fortunate enough to do it in a 5-year-old, and it was excellent. Persistent wheezers, those are the ones that start before the age of 3 years, and they continue beyond 6. They're usually atopic. There's a family history of asthma, and they can have eosinophilia. It's usually a high-risk asthma with reduced lung functions that we can see. And these are the children where we would say, if we do not get control when they're young, they become difficult asthmatic adults. So this is a very important population group. And then the late onset wheezers usually starts after the age of 3. They have allergen sensitization, which can precede the wheeze. So this whole concept of the allergic march might be relevant in this group as well as the persistent wheezers. And they can develop allergic asthma late on in life. So I did my MMed, and my study was what's the incidence of allergy in asthmatic children? And we found that 50% of all asthmatic children are allergic in Pretoria Academic Hospital that was visiting there. Given they come from all over the northern part of our country, but still, it's quite significant. So just to come back to the Tucson Children's Group, and this is exactly where I get my 13% from. And if you see here, 13.7% is the persistent wheezers, which can become the asthmatics. Only 15% is late onset wheezers, and 19% is, 20% is transient early wheezers. 51% of all children never wheeze. So people come to my office and say, Doc, I think my child might be asthmatic, although he's not wheezing. It does not mean it's not asthma. And that's the problem we have. So yeah, 51% do not wheeze when you see them. So if you look at ERS Task Force, they actually brought up the 2 base symptom phenotypes, the episodic viral wheeze and the multi-trigger wheeze. However, these phenotypes were not static over time because children would switch between the 2. So it was very difficult to actually distinguish which one does a patient fall into, because it can be one or the other, and at different stages in their lives it can fall into different groups. So we should avoid the term of asthma below the age of 5 years. So my running joke is, for the medical aides and for the grannies and grandfathers, it's asthma. And if they ask they might outgrow it, you say yes, probably, because it's not truly asthma. If you have asthma, you've got airway remodeling. It's done, it's dusted, you cannot get it away. So the parents often say, oh, I outgrew my asthma. It's because they never had asthma, quite frankly. Other terms that we can use is recurrent viral-induced wheeze, multi-trigger wheeze, and the pathology in these age group is not always eosinophilic airway inflammation driven. So that also does make things a bit more difficult. So if we look at the Global Initiative for Asthma Guidelines, they use their data according to evidence that was collected. And this was the guidelines for 2022. So they said there's a few symptoms which you should actually look at to help you diagnose asthma with below the age of 5. They say wheeze is a very common symptom of asthma, although I don't really see it in my practice. And earlier we've seen with the Tucson group, they didn't see it either. Cough can be recurrent or persistent, and that's probably the most common symptom I see. It can be accompanied by wheezing. So yes, when they're really sick, doctor, they wheeze, and that's the most common statement parents make. Nocturnal cough, very significant, and more often than not, I would ask them, is it with lying down or is it during dusk? And the issue is it's dusk. As soon as the sun sets, that's where the cough starts. And then it can persist during sleep and maybe in the early morning hours with the cold air as well. Exercise-induced cough. I have a few below 5 that will have it, but it's not a common presenting symptom. If it's there, then you know this kid is very likely to be asthma, to be honest. And then they have these recurring nocturnal coughs and exercise symptoms in the absence of the respiratory infections. They not necessarily have a viral infection, or they're not sick and they're coughing. So the supporting evidence that you can use according to GINA guidelines is to do either a trial of treatment or to do a short-acting bronchodilators and inhaled corticosteroids. So we usually do 8 to 12 weeks. Then you look at the clinical improvement. You can actually give the parents a scoring card where they can write down the amount of times of coughing, nighttime coughing, daytime coughing, exercise cough. Well, how often do they use the short-acting bronchodilator? And please take note, this is short-acting bronchodilators, not long-acting. We do not use long-acting below the age of 5. Then you can test for A to B, and we'll get to the scoring system that we use, which is quick and simple in the history taking. Chest X-ray, I must be honest, it's not something I do routinely in my office for the diagnosis of asthma. There is something like the risk for radiation, but I suppose if the child does come with an X-ray, it can assist you. So the diagnosis of asthma in children 5 years and younger is usually made if you have the following present: the recurring acute wheezing episodes. There's no other alternative diagnosis, and there's a positive response to your short-acting beta agonist during these episodes, or an marked improvement for 2 to 4 months with your inhaled corticosteroids with an as-needed short-acting. So that's what I do in my practice. I prescribe an inhaled corticosteroid for 2 months. I see them back in my office, and then we will do a total of 4 months and see how they go. I do a bronchodilator response test in my office, and we'll chat about that a bit later as well. So these are the criteria for definitely asthma. So if you see that there's 1 or 2 of them that can fit in, then you suspect asthma, and those are the kids we have to watch. But fortunately, they can actually still outgrow the asthma in inverted commas if it's suspected. The diagnosis is primarily a clinical diagnosis, but the problem is spirometry in this age group is very difficult. Some doctors do tidal volume breathing, but it's quite difficult to assess, and the kiddies has to be distracted and they have to be cooperative to actually do that. But in my office, I don't do it. I do a bronchodilator response test. So what features are suggestive of an alternative diagnosis? So if you look at, there's a continuous wheeze from birth or the onset after birth. If there was failure to thrive, there's feeding difficulty or persistent vomiting. The child has clubbing. there's chest signs, or you can hear a murmur, if there's recurring pneumonias or a persistent productive cough, and if there's no response to asthma. So my professor always used to say, the one thing with asthma is it does respond to cortisone. If it does not respond to cortisone, rethink your diagnosis. And that's very important. So I think that's one of the biggest lessons I've learned throughout my life, is that cortisone will work on inflammation. Yes, we're not talking about our older patients, but the younger ones. If there was a family history of unusual lung disease or immunodeficiency, or maybe an early infant death, then needless to say, you need to think further as well. So what are the common conditions? Foreign body aspiration, more often than not, that will potentially give you a unilateral aspiration and not bilateral. Cystic fibrosis, you do not want to know how many new cystic fibrosis diagnoses I've had who presented with recurring viral infections. It's actually quite shocking. It's not the failure to thrive, not the recurring pneumonias, but viral infections. Congenital airway abnormalities, PCD or BPD, especially if there was a bronchopulmonary dysplasia, and also your premature babies with the recurring wheezing. So the stepwise approach that Gina would suggest is, step one, you look at intermittent wheezing only with viral infections and there's no interval symptoms. Then you only use a short-acting beta agonist. Step two, if the symptoms are there for more than 3 times a week, or there's risk factors for exacerbations, like the parents might be smoking, then you use a daily low dose inhaled corticosteroids with short-acting beta agonists as needed. Some people will add legotrain receptor antagonist or montelukast. If the ICS is not tolerated, I must be honest, it's more often the other way around. And in my practice, I've lost favor regarding the legotrain antagonist because of the side effect profiles that we're seeing. And it has a black box warning at the moment for suicidal ideation as well in the US. Symptoms persisting after 2 to 3 months on a low dose inhaled corticosteroids means you have to up your dose. Just make sure technique is good and compliance is good, because more often than not, that is your first stop where you should start looking at changes. And then you might have to consider referral, because what often happens is the GPs or the pediatricians want to take the next step, but they're unsure, or they go too high, or they go to a long-acting beta agonist, where if they just went to a higher dose, they would have sorted it out. So I think it's important to realize when to refer. And then step 4 is when there's a poor control of frequent exacerbations, despite the increase in the inhaled corticosteroids. Then I start looking for other causes or secondary causes as well. And then you can look at add-on treatments or alternative treatments. The potency of the inhaled corticosteroids can also often make a difference, but you'll have to refer those patients. We would review these patients 2 to 3 months. So I do 2 months. And I usually tell the parents, the risk of an exacerbation in the first month is still good, but the second month it should be less. I can never stop it, but I can make it less frequent and less severe. So I think that's very important to tell them, because people think children should not cough at all, and that's not the case, because they will cough in between. If your child's in the nursery school this year, it was crazy. So and I don't know, everybody was coughing. It was really a tough year for me, to be honest, as a doctor. Once this patient population does well, you should do a step down of treatment, because children often don't need the long-term use of the inhaled corticosteroids. And I say they need to prove to me that they need it. And that is also part of diagnosing asthma in this age group, is that they need the treatment. So once you wean them, they start with the exacerbations again, or the recurring wheezing, and then you know. It's very important, if you have a child that's got a severe dog allergy and the dog sleeps in the child's room on its bed close to its head, that you need to address this and do trigger avoidance. And like I said earlier, look at the technique of the use of the spaces, etc., and compliance. It's still parent dependent to have them do it. And yeah, nowadays it is tough with social what do you call it? Yeah, just life happening, to be honest. So the asthma prediction index is something I use in my office. So it's part of my history. And the purpose is then to identify which of the recurring wheezing children has an increased risk for developing persistent asthma. And usually the children less than 3 years old and with more than 4 wheezing episodes per year. And you can confirm this with the clinicians as well. So how it works is we have a major and minor criteria. It will be positive if you have more than 4 wheezing episodes per year. So that's point number 1. And then you need to have 1 major or 2 minor criteria. So parental history of asthma, and that's current asthma, not as a child who outgrew it. Was there any diagnosis of atopic dermatitis by a doctor? And is the parent, one of the parents actually sensitized to an inhaled allergen? Minor criteria is eosinophilia of more than 4%. And is there wheezing that's happening apart from the cold? And is there any food allergies that can be diagnosed or is present in the family? So just recently, the South African Childhood Asthma Working Group set up guidelines. What's the best practice to diagnose these patients in South Africa? And as you can see, it was all the departments in our schools of medicine, Tuks, Wits, Stellenbosch and Limpopo. And they came up with a few suggestions. So step 1, take a detailed history. As always with everything in life, in our fields, is history. Is there recurrent wheeze? Is there cough? Is there any shortness of breath or chest tightness? Is it more often than not during viral episodes or periods where there's more viruses? Exercise, laughter, is it with a change of seasons, summer, going into summer where we see it, or spring, I should say? Is there variability over time? So is it worse at night or early in the morning? Because this is typical for asthma. Eh? Is there family history of asthma or atopy, like eczema or allergic rhinitis? So we did, I can't remember, it was my colleague who did a paper on the incidence of allergens in the mother and the link to having an allergen in the children. And it was a more than 50% chance that you could also have allergies if your mother was allergic. So it's quite common. And why did we test the mothers? Because in government, mostly it's the mothers that come with the children. Triggers and environmental exposures. We know if you're born to a smoker or if there's indoor pollutants, you are more at risk as well. And then an isolated cough is seldom due to asthma because it's more the persistent symptoms that will, there's a pattern. If there's a pattern, then you must think there's asthma. Your clinical examination and exclusions for other diagnoses should be done as well. You should assess for wheeze, look at a chest deformity or chronic signs. So we have what we call the Harrison sulcus, which is the implantation of your ribs on your diaphragm, and you have flaring of the distal costal areas, and that just shows you the child has chronic lung disease, may it be asthma or anything else. Examine the child for eczema, allergic rhinitis. We can look at the child's face. You know, they sit in front of you, and just by observing them while you question the parents, you can see if they've got an allergic facies. The allergic shyness, the allergic salute, open mouth breathing, and do they look run down? Because most of these kids do come across as being run down. You will need to make sure that you're not managing a bronchiolitis, bacterial bronchitis, tracheomalacia, cystic fibrosis, cardiac disease, aspiration, immunodeficiency, etc. I've got a flow diagram a bit later that will show you in detail how we can approach these conditions in these patients. And then a transient early wheeze is common and may resolve. And more often than not, we're all forced to put our kids at 4 months in a daycare. And these are often the kiddies that has the transient early wheezes. So is there evidence of airway inflammation or atopy? Because needless to say, that can predispose you to developing asthma. So once again, you have to check for eczema, allergic rhinitis, food allergy. Consider doing a serum IgE. I don't like a total IgE. I do specific IgEs. So listening to the history. Screen peak testing is far better. It's less painful. It's less invasive. You can do close to 17 things at once, and you've got to answer within 15 minutes, and it's visual, because needless to say, if a mum can see they have a reaction to grass, then they're convinced. So skin prick tests are quite convenient. And then if there's a presence of atopy, it increases your likelihood, but it's not diagnostic alone. So if you are allergic, you're not asthmatic, and vice versa. But your chances to have both is 50%. Therapeutic trials and assessment of a response. So like I said earlier, GINA suggested the same, and we tend to follow GINA quite strictly in South Africa because it is applicable. We do a 6 to 8 week trial of a low-dose inhaled corticosteroid and reliever therapy as needed. If there's improvement and relapse on withdrawal, we know it's probably asthma. If there's no improvement, then you have to reconsider your diagnosis or refer. If they're more than 6 years, you can assess inflammation by doing spirometry and peak flow. On the little ones, even like a 4-year-old, you can do a peak flow. The problem is there is a bit of a learning curve in children. So if they do the first 3 peak flows not particularly well, and you give them a bronchodilator in 15 minutes, you make them do it again, they probably have a better technique. But you need to keep that in consideration when you do observe them, and that's where your clinical judgment then comes in. So there's certain levels of diagnosis that you look at, and the level will be definite asthma, probable asthma, or possible asthma. And the criteria we'll use is as follows. So for definite asthma, there's the typical symptoms. There's a clear therapeutic response to treatment. When you withdraw the treatment, they relapse. And you've looked at all the other possible causes for asthma, and nothing was there. A probable asthma is they have typical symptoms. There's a partial response to therapy, or there's maybe a limited objective testing. You can't do a peak flow, you can't do a spirometry yet, or clinically you're not convinced. And then there's a possible asthma. So it's a suggestive feature, but incomplete evidence or possible alternative diagnosis have not been looked at or hasn't been excluded completely. So this is just a flow diagram of what they've suggested. So we do a therapeutic trial for 6 to 8 weeks, then you stop. If there's no change, you stop the therapy. If it worsens, then you can restart the treatment. So I know this is not below 5-year-old, but this morning I got a call from a mom with a 17-year-old. And a few years ago, I think 2023 was the last time I saw her, she was not really using her asthma treatment. And only now did she, the mom suspect she had an asthma attack. So yeah, it's a good 2 years that she's been able to use her treatment far less or even not at all. So we will definitely do that in the below 5 as well, and even more so than in the older age groups. So then the National Education Program for Asthma is also guidelines that we follow in South Africa. And what's nice about their guidelines is very practical guidelines and more based on technique and diagnosing as such. So the challenge is always not being able to do a lung function test, but we've spoken about that now, to avoid inappropriate prolonged asthma therapy. It's far safer than oral corticosteroids to use inhaled corticosteroids, but the point is it's children, and we always try to come off it. It's probably the one condition where if a parent comes to my office and they say, "Doc, you're going to fight with me, I've stopped the asthma treatment," I will probably not fight unless the child is sick. If the child has been well and you've taken him off his asthma treatment, then yeah, I'm glad, so I'm not too fussy about parents wanting to stop. But if they tell me, "Oh, I've stopped," and I say, "So when did you stop?" And they say September, and I said, "Since when has the child been sick?" September. Then I'm like, okay, put 2 and 2 together, and then the parents usually it dawns on them and like, "Oh, okay, we know." So yeah, common sense is also important. So the big thing we need to avoid is to underdiagnose asthma. So what they've seen is more often than not, the more viral infections these population groups, especially the below 5s, get, the more risk they have of developing asthma in the long run, specifically if it's RSV or rhinovirus. And they've also noticed that by treating these patients with inhaled corticosteroids, you decrease the risk of developing asthma. So people always ask me at parties, how come so many children are on asthma treatment, but they're not asthmatic? And then I tell them it's preventative, because it is preventative. So there's always labels that these kids get attached to: wheezing bronchitis, recurrent pneumonia, or the reactive airway disease. I don't know, I haven't come across reactive airway disease of late, but it is, some people can use it. Bronchitis, the wheezy bronchitis, I don't understand, but yeah, that's a common term the GP sometimes use. Then chronic airway inflammatory responses and structural changes that are characteristic of asthma can develop in the preschool years already. And this is why we always say that those persistent wheezers, we need to treat very aggressively and make sure they don't relapse, because they become the difficult asthmatics, and therefore indirectly we reduce morbidity by treating these patients. So a practical approach is, if you have a wheezing child, you have 4 groups that you can divide them into. You can divide them into the infantile wheezing, which is usually transient and virus-induced. The preschool wheeze can be viral or multi-trigger wheezed, but the problem is they can switch between them, so just keep that in mind. Then the sinister wheezing is the kids that can mimic childhood asthma, so it can be persistent, can be long-term, but they can often turn out not to be asthmatic, and then needless to say, the true asthmatic patient we should not be missing. And those are the ones it's probably more in your face. There's often a strong family history, meaning mom or dad is asthmatic. And then this child, the mom will say, listen, he's got similar symptoms to what I have. So there's factors that may prevent the development of asthma, and those are very important to know, because we need to advise patients when they are pregnant, or in my practice, I often see a firstborn, and then the mom's pregnant with a secondborn, and then we can give them advice. So your genetic factors obviously plays a role, your environment can play a role, and lifestyle. And there's certain modifiable exposures early in life that we can reduce to help to reduce the risk of asthma. So no tobacco exposure is very important, can help to reduce airway inflammation, and it's strong evidence in support of this. Breastfeeding, its immune modulation, there's some moderate evidence. A healthy diet, antioxidants or anti-inflammatories is also moderate. To reduce the pollutants, will decrease the airway irritation. That's very strong. Controlled maternal asthma. So if the mom's asthma is better controlled, can prevent fetal airway changes, and there's also a strong relation there. Then balanced microbial exposure. So normal vaginal deliveries is often better than C-sections, but easier said than done. And then avoiding the antibiotic or paracetamol overuse, which can protect your microbiome, is moderate. So let's look at a case. It's a 4-month-old little baby girl. She had fever for 3 days, started with a runny nose, and now she's coughing, and she was wheezing from the previous night. Now this is the breathing. You can see she's using her accessory muscles in quite severe distress. So this child was diagnosed with bronchiolitis because it was the first episode and she was still young. Which viruses can cause this? Most common RSV, rhinovirus, parainfluenza, influenza, adeno, human metapneumovirus, bocavirus, coronavirus, and COVID. The first two, need to say, is probably the biggest ones and the ones that causes the most problems. Although I've had bad adenovirus patients, and human metapneumovirus can make them quite sick as well. So why would you admit a bronchiolitis patient? Usually you would admit them if the oxygen saturation is less than 90% inland or 92% coast. If they have severe distress, cyanosis, grunting, lower chest wall recessions, if they're not feeding, if they have apnea. So the RSV kiddies can get apnea, and more often than not, the second episode is RSV. There's often more apnea that can take place. So the second episode of RSV, you need to watch them closely. Premature infants can obviously have higher risk and more vulnerable. So if they were ventilated for particularly long periods, they are vulnerable to these viruses. Nowadays, they all get their RSV vaccines, but not everybody, but yeah. If there's any underlying medical condition that can contribute to the severity of the disease, may it be a congenital heart disease, Down syndrome with smaller airways, or chronic lung disease. Needless to say, if the child is severely malnourished, then you need to also be very careful because the risk for secondary infection and deterioration is quite high. And then if the family is not able to provide the appropriate care, especially thinking about our government patients, and sometimes even in private, if the mom has to work and she works shifts or something, then we need to accommodate them. So unfortunately, bronchiolitis is quite a difficult treatment regime because everybody thinks they're wheezing and they're struggling. We have to give asthma treatment. We have to give cortisone. But as a matter of fact, very infrequently do we need to do all of those. So the happy wheezer, we're going to just support. We're not going to do chest physio. We're not going to give steroids. We're not going to nebulize. We're basically going to watch them and wait. And then if they're very ill to wait, then we will start them on high flow nasal cannula oxygen, which works very well for this population group. Do basic bloods, chest x-ray, if we have to, in invasive ventilation. And these patients often end up getting antibiotics because of secondary infections. And then if there's masqueraders or comorbidities, then think about other causes: TB, structural abnormalities, compression, foreign body, acid reflux, and antibiotics can be considered depending on the comorbid condition. So if you have an immunodeficient patient, for instance, you will probably consider adding antibiotics, or cystic fibrosis patient, you will add antibiotics. So the childhood origins of asthma study, it was done in Wisconsin, they followed very high-risk infants. So there was parental asthma and allergy from birth, and they found that these patients will get rhinovirus wheezing illnesses in the first 3 years, which was a very strong predictor for asthma at the diagnosis of 6. So this is the 13% that become asthmatics. It's much stronger with RSV, but we know that RSV is a terrible disease, and they can wheeze for months afterwards, and then needless to say, they can develop asthma like we see here. The risk for asthma at 6 years is tenfold higher if the child had rhinovirus-induced wheezing compared to a child who's never had it. And there was a persistent association was seen even after adjustment for atopy and parental asthma. So yeah, these two viruses are big triggers for the development of asthma. So why is rhinovirus such a big factor in asthma? So if you're an atopic person, you have increased ICAM1 receptors, which is where your atopy, your allergens actually can attach to your airway, and there's decreased lambda interferon. So your rhinovirus actually uses these ICAM1 receptors to attach to your airway, and therefore you are more prone to infections and asthma exacerbations. And the more this happens, the more remodeling you get. And once you get remodeling, you've got asthma. So then there's other recent evidence. The INSPIRE study showed if you avoid RSV in infancy, you can lower the risk by 26%, which is actually shocking. It's excessive. Frontiers of Pediatrics, viral infections can alter your airway epithelium and your immunity. We know this. Ben Tuami said that early antibiotics can be linked to higher asthma incidence. So especially antibiotics in the first year of life can be associated. And here you can just see all the other articles as well. And you can see the most recent study, the age of RSV infection study, that if you had RSV hospitalizations between the age of 6 and 23 months, you have increased development of asthma later on in life. So this is one of my questions if I see patients, is did you ever have RSV or rhinovirus infections? So patient 2, 9-month-old baby boy, born at 34 weeks, birth weight was 2.1. First admission was at 8 weeks with rhinovirus and RSV. He was on 4 days of nasal bronch oxygen, and since then he's wheezing often, even when he's not sick. And as you can see on his cheeks, he's got quite severe eczema, and the mother had asthma as a child. So if you look at the asthma predictive index, this child has a high index for development of asthma. So if we look at the multi-trigger wheeze, according to our GINA guidelines, we would start them off in step 1 by just watching and waiting, but then a lower dose inhaled corticosteroids will be added. And you can decide if you want to start off with a leukotriene antagonist. I don't do that anymore. I find side effects are too high. I just go to the inhaled corticosteroids. If I'm really desperate and I can't get control, I'll add a leukotriene antagonist, as you can see later on in the other steps. And then if the child doesn't respond, you move to step 3 and you double up your dose. And then step 4, you can refer to a specialist if they still don't improve. You can consider the bottom step, the column there, if there's infrequent viral wheezing and no or few interval symptoms, that you can give a short-acting beta agonist if there's not frequent wheezing, and you can use it at intermittent periods. I'm quite hesitant of this because people tend to abuse the short-acting beta agonists. I'd rather go to a low dose inhaled corticosteroids, and I know the baby is going to be safe and people want to abuse the SARBAs. And then patient number 3, a 1-year, 2-month-old baby, born by C-section, term 3.5 kilograms, no complications. She started creche at 4 months. She wheezes when she's sick, but it gets better when she's not sick. Oops, sorry. So this is a child with an episodic viral wheeze. You support them. You can give them symptomatic treatment during these episodes. You can do a trial of a bronchodilator. As I said earlier, just be careful. And you can do in your office a modified bronchodilator test. How that works is you don't have to nebulize. You can use a spacer with the SARBA, and you assess the child's respiratory rate. If you have an oxygen saturation monitor, you can do that, and you clinically auscultate. Then you give them the bronchodilator, 2 puffs of 100 microgram bronchodilator, and you wait 15 minutes and you reassess the child regarding the rest. And if there's an improvement, then you know the child might benefit from a trial of inhaled corticosteroids. And needless to say, you have to reassess and you have to consider to stop the treatment, always. And then patient number 4, the 2-year-old baby boy, blocked nose from day 1 of life, noisy breathing, secretions and wheezing every day, failure to thrive. That's the big giveaway. And he does not respond to inhaled corticosteroids. These are patients you do not stick around with, you refer them. The big giveaway is a failure to thrive. We have to weigh and measure these children every time you see them, because that's the signs that there's something sinister going on. So what's your differential in children of diagnosis of asthma in a child less than 5? Your recurring, well, first of all, infections. I mean, we know this, especially this year, like I said. Recurrent respiratory tract infections, your chronic rhinosinusitis, TB, HIV disease. Not something we see often in private, but we tend to forget about it, so we should look at it. Your congenital problems, tracheomalacia, cystic fibrosis, bronchopulmonary dysplasia, congenital malformations, primary ciliary dyskinesia, immune deficiencies, and congenital heart disease. And then mechanical problems where you have a foreign body or reflux disease. So this is the little flow diagram I said to you earlier. When should you do a further workup of a child? So first of all, you always weigh them and measure them. Don't forget the height. Height is your best predictor of chronic disease. If they are thriving, and it's really a very early age of onset, and you say yes, you look at the episodic viral induced wheeze. If it's yes, then it's viral. If it's no, it could be asthma. If it's not an early onset and they are atopic, then it could be asthma. If they're not atopic, look at other triggers like exercise or emotion or smoke. And then you need to make sure if there isn't any other causes. So that's when you look at your chest x-ray. Consider a sweat test, a TB workup, HIV, induced sputum, bronchoscopy if it's really necessary, and immune testing. So just to come back to the correct use of a spacer, yeah, people love nebulizing, and the only reason I would nebulize is if the child has croup. There's no other reason for nebulizing. People often say, yes, but why do you nebulize in hospital? It's because we can use 100% oxygen in hospital. We do not use room air. And if you use a nebulizer 100% correct versus using a spacer correct, your deposit of the medication may be inhaled corticosteroids through a spacer is only 40%, 40. But with a nebulizer, with constant sealing over the mouth and completely finishing the dose of the medication, it's only 30%. A spacer takes you 6 breaths in and out. So you make sure the seal is correct. If they cry, you do it for longer. People think when they cry, you have more effective breathing. That's not. They hyperventilate. So you have to check that they inhale and that they don't rush, because that's often what the kids do. In the beginning, most of them will fight and cry. I tell the parents, give them the spacer, let them play with it. If there's an older sibling, let the older sibling do the spacer and play, give them medicine. But the idea is that if you inhale and exhale in your spacer, you circulate the air, and by doing that, you get more deposition of your medication in the lungs. And the chamber has to be small enough, because you're actually mimicking the tidal volume of the child. So you can imagine if you've got a big spacer in a 2-year-old, it's not going to work, because they'll never get the circulation of that amount of air if they have a smaller tidal volume than what the size is of the chamber. So yeah, so that's Dr. Rue's talk, and there's some references if you were interested. And yeah, you're welcome to ask questions.
Thank you, Dr. Els. I just want to firstly say thank you for that very interesting, it's a very current and relevant clinical and evidence-based presentation. I know it's Dr. Rue's, but I think you did it justice, and it was really, really interesting to listen to everything that you said. And for some of us, we love the evidence and the clinical guidelines and those flow charts that really make it easy to follow. And obviously, from a clinical perspective, I found it very interesting, because I don't deal with pediatrics per se, but I know your colleagues here that deal with them every day, and I am very sure that the attendees have a lot of questions and comments for you. So I'm going to open up the floor. So you can put up your hand. If you want to put on your camera, please do. Introduce yourself and unmute before you ask your questions. And let's see how we go. I think that's Marley.
Hi, yes, my hand is up, very eager. Doctor, thank
Easy
you so
questions.
much. That was beyond interesting. I don't know. I probably took like 20 screenshots.
I'm sure if you ask Dr. Rue, I can't see that she will have an issue to give you guys the talk. So for Anna, maybe you must make contact with Dr. Rue, and yeah, I never mind. So
I
I'm sure she
definitely
won't
will.
mind.
Oh,
Yeah.
thanks so much.
Definitely will.
I'm going to ask a question as a physio and as a mom of a almost 7-month-old little girl. So have you found any kind of like correlation? Oh, there we go. There goes my English, between food allergies and asthma?
So not directly. What can happen is the children can go through the allergic march. So only 2 to 5% of the little ones can go through the allergic march. So in the past, we used to think they get eczema and then food allergy, but we know now it's probably the opposite way around. They get food allergy and then they get eczema, and then they get allergic rhinitis, and then they can develop asthma. So I always tell the parents who come in with eczema or known food allergy, watch out for the chronic runny nose. If you start seeing that chronic runny nose, then you should start treating it. And because if that's not treated, it will lead to asthma in the long run. But it's rare. It's not a direct cause of asthma, but it's indirectly linked due to the atopic march.
Awesome. Thank you so much. See, there I asked my personal question. And then secondly, it's just a thank you, but thank you for saying physio shouldn't treat bronchiolitis. I feel it's a very under-researched and over-treated field in physio, unfortunately. But yeah, that's very nice to hear that the evidence is there and that we should actually not be treating these patients.
Yeah, the problem is, I think it's the pressure from the parents, né? And I mean, it's very frustrating, because all we try to do is to educate them, and then they still, and I mean, listen, I'm grateful for staying in South Africa, because we can walk into a doctor's room and see them, and we can go to a physio on our own choice, you know. But that is probably where Europe is a bit better, because you need the referrals. But I think, you know, common sense, in the sense of, if this child's really wheezing and I'm going to bash him on his back, I'm probably going to aggravate things, and just keep that in mind. And I mean, I work a lot with the physios because, quite frankly, I think you tell us more than what the doctors can tell us. So I always tell the mom, if they email me or phone, and I said, man, see if you can see a physio, and then you ask the physio to phone me, because I can ask the physio, is she wheezing? Is she coughing? Is she phlegmy? And you guys actually do that. You actually phone us back, and you actually do listen to what we have to say. Whereas, sorry to say, most doctors don't listen to each other. No? We all have our own opinion. So yeah, thanks for you guys as well, because I do think you sit at the bottom end of the referral, and sometimes the most difficult end.
No, thanks so much, Doc.
I think we have let me just check. It's Karin. Karin, you have a question. You have your hand up. Please go ahead.
Thank you so much. I'm also a physiotherapist, so thank you, Dr. Carla. It was really informative. I would like to just ask you what you feel the supporting the upper airway, what difference that can make in the children that are wheezing, whether they're asthmatic or not asthmatic. I work in the East Rand, and a huge part of my job is actually just teaching parents to do nasal hygiene, because I feel that if you can support the upper airway, the lower airway actually doesn't take that much strain, and they actually just breathe better. So I don't do percussions and so forth. I basically do lavage and education for a lot of the patients that gets referred.
So, I mean, I'm a strong believer, because we talk about the united airway. So nose and chest goes together. Where does the virus start? It starts in the nose. So we have to clean the nose. The problem is, in the younger age group, is you don't want to create aversion with the nasal sprays and suctioning too often. Lavage is, I mean, if you can do a nasal douche with either just normal saline or even with a flow, I mean, I love it. My son hates it, and he says to me, "Mommy, I don't want to do it." And then he says, "Oh, it's so much better afterwards." So,
Yes.
and he's 9. He's 9, So yeah, they're 4, but it does help. They can't blow their noses. They can't even sniff. If they can sniff, you can tell them to bloody well sniff, but they can't. So it's really. I always joke and I say the nose is the start of all evil. And we have to focus on the nose, but a big but, you cannot always suction, and you cannot always just keep on spraying. You have to be patient specific, and you have to take into consideration this child is very sensitive. I can't douche. My ears are terrible. I had so many ear infections as a child. If I douche now, I cry. I get such earache. So if you are going to rinse and the child keeps on crying, maybe just have them looked at, So I think, once again, common sense, né? And it's not always dished out in the first cue, but we all have it. So use that. And if it persists, I always tell my patients, if they come to me and they say, "Doc, I've got allergies, that's why I've got sinusitis," and then we get the allergy test back and it's not particularly significant, then I also look at immunity issues, because chronic sinusitis is the most common presenting sign for immune deficiencies, and we shouldn't underestimate it. So that, once again, is an indication. Look further.
That's actually very interesting. My husband he's got chronic sinusitis, and I didn't really understand where it was coming from. And when he was admitted with quite a serious thing, his CD4 count was extremely low. And saying what you're saying now, it makes sense. But thank you so much. I really enjoyed the talk.
Pleasure.
Thanks, Gordon. Anybody else? You have the doctor on the line. Please put up your hands and ask your questions. Any other questions or comments?
Anything. I'm here now.
Yeah.
I also just like to quickly butt in with another thing. Is I'm very appreciative of the fact that you mentioned that no antibiotics, or not giving antibiotics until they've aged 1 at least is actually such a good thing, because that's a lot of times that what we advocate for is just wait 3 days. If it's a viral infection, just give us 3 days to get you over the worst of the symptoms. and rinse the nose and do whatever we can to support. But again, parents wants to use antibiotics, and if you can have that study and say to them, well, here's a study that proves, don't use it.
So the other thing you can do is I do emergency plan for my patients when they go out. So they get instructions what to do, and at the bottom I say, do this for 3 to 5 days. If they get worse, you call me. Because the Cochrane reviews have shown in the age group above 6 months, if you wait 3 days, there is no increase in morbidity or mortality of these children. So you've got time. And usually day 3 is the worst day. By day 3, the mom will either phone you or she'll say, oh, it's probably over the worst. And by day 5, they don't stop coughing. Don't get me wrong, but they don't get worse.
I like to say to the parents, don't phone the GP, phone the pediatrician. You'll probably get an appointment in 3 days' time. If the child is not better by then, please go to the pediatrician.
No, definitely. But yeah, I don't prescribe antibiotics a lot. 90% of the time it's viral. Needless to say, if the child is toxic and they just deteriorate all the way in those first 3 days, it's a different ballgame there. And yeah, please, colored mucus from the nose, if it's green or yellow, does not imply they need to get antibiotics. It's just your white cells being broken down.
Awesome. Thank you so much.
Pleasure.
So I didn't see any hands going up while Karen and you were discussing. And it is 8 o'clock, so we're not going to keep anyone waiting. So if there really are no more questions and comments, Dr. Els, thank you very, very much again.
Pleasure.
We really appreciate it. It really was more than interesting, like Marley said. And all the best wishes for Dr. Adele for recovery. And we'll ask for the presentation. We'll definitely share. And just for the attendees, please don't forget CPD activity. So don't forget to do your CPD. And thank you once again, and have a lovely evening.
Thank you. Bye-bye.
Bye, everyone.
Bye.